Dr.
Good
Mamta.
morning, everyone, and thank you, Nilesh Mohan sir, for giving me this opportunity. I'm going to talk, or I'm going to discuss how successful we are, or where exactly we stand as a clinician in giving a good quality of life to our glaucoma patients. I have no financial interest in this. As has been told earlier, glaucoma is the third leading cause of blindness in India and causes nearly 12.8% of country's blindness. And the goal of glaucoma treatment is to maintain the patient's visual function and the related quality of life at a sustainable cost. In our clinical practice, we get to see the complete spectrum of glaucoma disorders. There are patients who have just been diagnosed with glaucoma, but they do not have any visual problem because of glaucoma per se. On the other end, we have patients who are completely blinded because of glaucoma. So when we are talking about quality of life, we have to talk on an individual basis. We have to think about each and every one of them. So how exactly we define the quality of life? Quality of life is defined as individuals' perception of their position in life in the context of the culture and value system in which they live, and in relation to their goals, expectations, standards, and concerns. Glaucoma affects the multiple aspects of quality of life, be it psychological, socio-economical, physical, and ocular comorbidity. We'll start with the psychological factor. As soon as the patient is diagnosed with glaucoma, he lives in this constant fear of having a chronic, irreversible, and a potentially blinding disorder. And the prevalence of anxiety and depression is much more common in these patients. And this psychological burden keeps on increasing as the vision goes down and as the glaucoma progresses. Then there are certain limitations which become a part of glaucoma patients, like going out alone from home, reading, night vision difficulty, judging distance, crossing road, and that is the reason why history of fall and RTA is much more common in these patients. There have been multiple questionnaires which are used to assess the physical limitation in these patients. This is a very popular one based on 15 of the routine activity which we do in daily life, and this can be used to assess the physical limitation of the given patient. Then comes the socio-economical factor. Self-administration of drop requires manual dexterity, eye-hand coordination, and good vision. All three go down as the glaucoma progresses. So ultimately, the patient becomes dependent on family or friends for putting the drops. And this becomes much more difficult when the patient is traveling, because most of the glaucoma medications, they need to be put at a particular point or particular time. Then comes the economical factor. As Dr. B.P. Sinha said, glaucoma is a lifelong disease and a significant cost factor is associated with it. It can be both direct or indirect. Direct cost factor was the patient is spending on medication or on different procedures related to glaucoma, be it diagnostic or therapeutic. Direct non-medical, what he or she is spending on transportation and nursing home care, and indirect cost, what the person accompanying the patient and the patient himself would have earned on the day of hospital visit. This is a very interesting study published in IGO2015 by Nayak et al., according to which nearly 60 to 65% of the glaucoma patient require 2 to 3 medication. And if we talk about the monthly income versus the expenditure, that is the consolidated expenditure, then a person from lower income group from a remote area is spending nearly 42% of his income on glaucoma treatment, which is really huge. Then comes the ocular comorbidity. Ocular surface problem is again very common in glaucoma, and these patients, they keep on complaining of burning, stinging, tearing, dryness, etc. Even after anti-glaucoma surgery, there is a constant presence of foreign body in eye because of the filtering bleb. These are mainly due to preservatives which are present in this medication. They have got detergent effect, cytotoxic effect, and immunoallergic reaction. As we can see, most of the anti-glaucoma medication, they are associated with one of these. These are some of the examples. So we know that we are in trouble. So what is the solution or what is the way out? If we talk about the psychological aspect, we need to educate the patient. We have to make them understand that glaucoma is not the end of it. They can have a very happy and productive life just by following certain indication, just by going through some surgical procedure as and when required. So we have to make them understand this. Whenever needed, we can go for low vision aid, be it field expanders or different kinds of magnifiers or whichever the patient needs. We need to refer them at the right time. That is the rule. And if we talk about the difficulty in putting the drops, then we have many devices available in the market which can help the patient in putting the drop himself or herself. Then there is another method which has been proposed by Reach and co-workers, according to which the patient has to hold the drop in the dominant hand, rest the forefinger of dominant hand over the forehead, and the thumb over the forefinger of the non-dominant hand. With this method, one can very safely put the drop. But this we need to teach our patient, and we have to instruct them how to do it. Then for decreasing the cost factor, we need to shift to fixed drug combinations. Now we have multiple combinations available, be it prostaglandin with beta blockers or beta with alpha-2 agonist. So one can shift from one to another as and when required. For decreasing the ocular comorbidity, we need to decrease the preservative exposure. This can be done by reducing the number of drop, as the benzalkonium chloride toxicity has been found to be dose dependent. So for reducing the number of drop, we need to shift to a long-acting preparation like prostaglandins, or we can shift to fixed drug combination where ultimately the number of drops would be lesser. Then we can shift to preservatives who are more ocular surface friendly rather than back. Like the safer ones are purites, softgea, polycoid, etc. Or now we have this option of shifting to preservative-free formulation also, which are available in unims or different multi-dose formulation with the help of ABAC and Commode system. But the ultimate quality of life will be dependent on compliance of the patient. We have to keep on emphasizing it all the time. So these are the certain points which we can use for in our clinical practice, in our routine practice, for improving the quality of life in our glaucoma patients. Thank you.